Hello, and welcome to an evidence-based approach to the abdominal exam, a video produced in conjunction with the UC Davis School of Medicine. In this video, we'll provide a quick overview of the evidence-based physical exam, discuss an evidence-based approach to physical diagnosis and common presentations of abdominal pain, and finally provide a video of a UC Davis Master Clinical Educator demonstrating high-yield physical exam maneuvers that every UC Davis grad should know and the evidence supporting them. Appropriate hand hygiene before and after each physical exam has been well studied and proven to reduce morbidity and mortality in the hospital and clinical setting. We all know the four basic tenets of the abdominal exam: inspection, auscultation, percussion, and palpation. And while these provide the foundation for our abdominal exam, this video will discuss a different approach. An evidence-based approach to the physical exam begins with a diagnostic question. For example, does this person have chronic anemia? To answer the question, you first estimate a pretest probability, which is essentially your best guess as to how likely you think this patient is to have the pathology in question, based on aspects of their history, presenting symptoms, etc. It's generally expressed as a percentage. Using this as your starting point, you choose an evidence-based physical exam maneuver, which, depending on whether the test is positive or negative, will feed back on your original hypothesis, giving you a new post-test probability, as demonstrated in this figure. For example, if you don't think that your patient is anemic, giving them a pretest probability of 20%, but then you discover conjunctival pallor on exam, that really changes your thinking, giving you a much higher post-test probability. How much a given physical exam maneuver changes your pretest probability depends on the sensitivity and specificity of the test, which in this case is expressed as a function called the likelihood ratio. You can see in the figure how a positive or negative likelihood ratio can affect your pretest probability either a great deal, for example if you have a positive likelihood ratio of 10 or more, or barely at all, for example a likelihood ratio close to 1. Let's see how this applies to the patient presenting with abdominal pain. So let's look at a distinction that physicians are often required to make in evaluating patients with abdominal pain: whether or not the patient has a so-called acute abdomen or peritonitis. Now we approach this problem by first coming up with our pretest probability, which again is our best guess as to whether or not we believe this patient has an acute abdomen, and how sure we are of that guess based on the patient's presenting symptoms and aspects of their medical history. Where did the pain start? What's the location of the pain? What are the provoking and palliating factors? What's the past medical and surgical history, etc.? From there, we choose evidence-based physical exam maneuvers that will either increase or decrease the likelihood that this patient has an acute abdomen. Below are physical exam maneuvers that have been well studied, along with their positive and negative likelihood ratios. A couple have been highlighted as being particularly useful. For example, the presence of rigidity has a positive likelihood ratio of 3.7, which means that if the patient has abdominal rigidity when you're examining them, they are much more likely to have an acute abdomen than if they didn't. The cough test, which has significantly increased abdominal pain when you have the patient cough. Evidence of peritoneal inflammation exacerbated by an acute increase in intra-abdominal pressure has a moderately good negative likelihood ratio of 0.4, meaning that if they do not have a positive cough test, they are significantly less likely to have an acute abdomen. Finally, let's take a look at Carnet's sign, which, with a positive likelihood ratio of 0.1, is probably the most predictive test we have for ruling out an acute abdomen. Here's UC Davis Master Clinical Educator, Dr. Mark Henderson, to demonstrate.
So now I'd like to demonstrate Carnet's sign. Carnet's sign is a physical finding that's associated with abdominal wall tenderness. So this would be used in a patient who complains of abdominal pain. After localizing the tenderness, let's say the patient has pain here to the left of the umbilicus, you would localize the pain and then actually ask the patient to lift both of their legs like this, and by contracting abdominal muscle wall, that will exacerbate this pain or make it worse. Let's try that one more time. So once you find the location of the pain, you ask the patient to raise both legs, which worsens the pain. Go ahead and put your legs down. That suggests if the pain does get worse or is exacerbated by contraction of these muscles, that the pain is coming from the abdominal wall rather than an intraperitoneal process. Now, an alternative way to do this that's easier for some people is to ask them to actually put their hands behind their neck. And then what I want you to do is I'm going to find that spot again. And then when I tell you, I want you to do a half sit-up. And let's see if that makes the pain worse. Go ahead. And okay, excellent. Again, if that brings on the pain or exacerbates the pain, it suggests abdominal wall pathology rather than an intraperitoneal process.
As you can see, other physical exam maneuvers, such as tenderness to percussion, rigidity, and rebound tenderness, are also useful in either ruling in or ruling out peritonitis, depending on their positive and negative likelihood ratios. Here's Dr. Henderson again to talk about his approach to the patient who may have an acute abdomen.
Examining the abdomen for peritoneal signs, typically we want the patient completely supine. Occasionally we can also raise the knees like this. You put a pillow under the knees to relax the abdomen, especially the abdominal muscle walls. That allows you to palpate more deeply in the abdomen. One of the quickest ways and the easiest ways to detect peritoneal inflammation is just to do percussion, to do light tapping or percussion, which can reproduce the pain.
Next, a demonstration on how to elicit rebound tenderness. Watch how Dr. Henderson gently pushes in on the abdomen while he watches his patient for signs of discomfort or pain. He holds the position, then abruptly lets go, and watches the patient for wincing or increased pain.
When I let go, he had more pain. Let's try that one more time. So again, I'm going to be palpating and then observing the patient closely as I palpate, and then you can see when I let go, he seemed to have more tenderness. So that would be a sign of peritoneal inflammation.
So let's take a look at McGee's evidence-based physical diagnosis calculator to see how some of these likelihood ratios play out. We start by selecting peritonitis from the drop-down menu. And this gives us a range of pretest probabilities for the presence of peritonitis. Now let's say that we're reasonably certain that our patient has an acute abdomen, so we set our pretest probability at 40%. And on exam, we see the presence of abdominal wall rigidity. Remember, that had a positive likelihood ratio of 3.7. So you can see now when we look at our post-test probability, it's greater than 70%. So we go from 40% sure that our patient has an acute abdomen to 70% sure. Okay, let's say we have them do the cough test and it's negative. They don't have any increased pain when they cough. That has a negative likelihood ratio of 0.4, bringing our post-test probability down to around 20%, about half as likely that this patient has an acute abdomen. Finally, let's say they have a positive Carnett sign. Well, we go from 40% certain that our patient has an acute abdomen to less than 10%. You can see these illustrated on the graph right here. The next condition we're going to talk about is appendicitis. Again, the first thing to do is look at the pretest probability. In this case, you'll estimate it based on the patient's history, location, radiation of pain, the onset, associated symptoms such as anorexia, nausea, vomiting, the patient's past medical or past surgical history, and also using validated tools such as the Alvarado score to help you predict the pretest probability in this case. Next, we look at the evidence-based key physical exam maneuvers. You'll note that right lower quadrant tenderness has a positive likelihood ratio of 1.8 and a negative likelihood ratio of 0.3, making it good at ruling out appendicitis, or making it less likely at least. Tenderness at McBurney's point has almost double the positive likelihood ratio at 3.4 and a negative likelihood ratio of 0.4. Note that Rovsing sign, Sowa sign, and obturator sign, three commonly taught physical exam maneuvers for the assessment of appendicitis, have negative likelihood ratios that are either not significant or approach 1, making them virtually useless in ruling out appendicitis. However, with positive likelihood ratios of 2.3 and 2.4 respectively, Rovsing sign and Sowa sign can be useful in the right clinical context in concert with other physical exam findings to help make appendicitis a more likely diagnosis. Here's Dr. Henderson again to demonstrate some of these physical exam maneuvers.
At this point, you need to be familiar with two landmarks, the umbilicus and the anterior superior iliac spine, which in this patient is right here. Let's see, it's a prominence. You can follow the iliac bone around the side and up to the front. So the anterior iliac spine right there and the umbilicus. Draw a line, and then you go up 2 finger breadths, or about 2 centimeters. And so that is McBurney's point. So another test or physical finding suggestive of appendicitis is Rosving's sign. So typically we're attempting to elicit and localize tenderness to the right lower quadrant. But with Rosving's sign, as you palpate on the left, in the left lower quadrant, either with pressure or release, this provokes tenderness in the right lower quadrant again. So as I palpate around the abdomen, looking for signs of rigidity, pressure in the left lower quadrant or release of the pressure in the left lower quadrant will provoke the right lower quadrant tenderness of appendicitis.
Next, the psoas sign.
So what we do here is actually try to get the patient to contract the psoas muscle, and that reproduces the abdominal pain. So one way to do this is in the supine position, where you put your hand above the patient's knee. I want you to bend at the hip, lift up your leg. This movement provokes the pain. Again, put it back down again. Okay, lift your leg. Okay. The psoas sign can also be demonstrated like this. So I'm going to have the patient lie in the left lateral decubitus position. I'm going to put you on the left side here. Okay. And then what we're going to do here is we're going to have him move his leg back, stretching the psoas muscle like that. That's going to provoke the pain.
It's also possible to elicit the psoas sign with the patient standing by having him extend his hip and watching for signs of pain in the abdomen or right lower quadrant. I wanted to take a moment here to talk about the data from another source, JAMA's The Rational Clinical Examination. These likelihood ratios represent the pooled results from 11 different studies encompassing thousands of patients, and they differ slightly from the data found in other sources. One thing I'd like to point out is up at the top here, they essentially pool together tenderness in McBurney's point and just right lower quadrant tenderness in general into one finding. And that increased the associated positive likelihood ratio to around 8 and the negative likelihood ratio to around 0.2, with very consistent finding between studies, meaning that right lower quadrant tenderness, just in general, is very, very predictive, either ruling in or ruling out appendicitis. In their review, they also found rigidity to be predictive of appendicitis, with a positive likelihood ratio of 3.8, although the absence of rigidity wasn't really as good at ruling appendicitis out. Note that other tests for peritoneal irritation, like guarding and rebound tenderness, were not consistently predictive of appendicitis. One more interesting fact from this data analysis is that the pooled prevalence of appendicitis in non-pregnant patients younger than 60 presenting to the ED with abdominal pain was 25%, while for patients older than 60 it was only 5%, meaning that, knowing nothing else about a patient, if they come to the ED with abdominal pain and they're younger than 60, there's a 25% chance that patient has appendicitis, while if they're older than 60, there's only a 5% chance. These are numbers that could really influence your pretest probability when you need to come up with your differential in the ED. Here we are back at McGee's evidence-based physical diagnosis calculator. This time from the drop-down menu we select appendicitis. Notice it gives you a wide range for pretest probability. You'll choose from somewhere in this range based on the patient's presenting symptoms, maybe based on their Alvarado score. Let's say we pick 60%. Now I want to say a word about Rosving's sign. Remember, the negative likelihood ratio for Rosving's sign was about 0.8, so let's dial that up. Let's say we get a negative Rosving's sign on exam. Notice that the post-test probability is about 5% less than our pre-test probability. It hardly budges at all, meaning that a negative Rosving's sign doesn't really mean much. Now let's say we get a positive Rosving's sign. That's a likelihood ratio of 2. It makes it about 15% more likely that our patient has appendicitis based on the results of that exam. So not a huge change. And that's why Rosving's sign is not a commonly used test. Here is a graphic of many of the different physical exam maneuvers that we discussed. Note that a negative Robsing or SOA sign is not even on this scale, and that's because their negative likelihood ratio are close to 1. They're not significant. They don't change the likelihood that this patient does or does not have appendicitis. I wanted to say a word here about the Alvarado score, which is one of the oldest tests that we use to evaluate appendicitis. Originally, it was based on a single hospital study in Philadelphia in 1986, but since it's been retested and validated several times. And in general, even though there's many other tools out there that are similar, people keep coming back to the Alvarado score as a good way to initially evaluate a patient who may have appendicitis. People often remember it by the acronym MANTRALS that you can see here in the figure. And it's a combination of symptoms, signs, and lab values that, if greater than 7, points towards a diagnosis of appendicitis. I also wanted to point out that while the Alvarado score is great in coming up with your pretest probability, it can also be used as a test in its own right. An Alvarado score of greater than 7 increases the chances a patient has appendicitis with a positive likelihood ratio of 3.1, where a score less than 4 decreases the chances that a patient has appendicitis with a negative likelihood ratio of 0.1. You have to be careful, though. Below are the results of what is probably the largest meta-analysis that's been done to date, comparing all the different tools that people have come up with for the evaluation of appendicitis. And you can see that the pooled results for the Alvarado score indicate that it misses appendicitis about 65% of the time, which is why, while it's a good starting point, we still need things like our evidence-based physical exam and imaging studies to cinch the diagnosis. In conclusion, I'd like to review just 4 take-home pearls from this presentation. The first is when you're assessing for an acute abdomen, the presence of rigidity and tenderness to percussion are actually better tests for ruling in an acute abdomen than rebound tenderness. Second, keep Carnett sign in your repertoire for the initial exam of a patient presenting with abdominal pain, as it is very useful in helping to differentiate between abdominal wall pain and visceral abdominal pain like you'd see in peritonitis or appendicitis. Third, while right lower quadrant tenderness and tenderness in McBurney's point are useful in the evaluation of appendicitis, Rovsing, SOAS, and obturator tests, as individual tests, have not been shown in studies to be useful in ruling in or ruling out appendicitis. Finally, while by no means perfect, the Alvarado score is an easy-to-use and validated tool for either coming up with your pretest probability or using as a test in its own right for the evaluation of a patient who may have appendicitis.